No. Okay. Again, I want to thank you, the scientific committee, the panel, and also Enzo for inviting me. This is a fairly straightforward talk. I'm going to talk about the use of topical linazolid for recalcitrant gram-positive corneal ulcers. And I thank you for your attention and sticking with me this afternoon. Resistant bacterial keratitis is an emerging problem all over the world, including the United States, also here in Italy and also in India and many other regions. Dr. Kay went over antimicrobial sensitivity testing yesterday, realizing that for the eye we have the significant benefit of being able to use topical medicines, not only because they're more effective and you can achieve higher minimum inhibitory concentrations, but also you can use medications in a way that does not contribute to systemic toxicity. So there are many different candidate compounds that we can use for the eye that can't necessarily be used elsewhere. And so as far as topical ophthalmic therapy, Dr. Kay made the point that MICs that you get from your laboratory in the hospital are not what are appropriate for use in the eye because the ophthalmic breakpoints tend to be different, meaning that the achievable concentration you can get with topical therapy is far different from systemic therapy. And so an antibacterial that's not effective necessarily at concentrations you can get in the rest of the body may be very effective in the eye because you can achieve higher concentrations. The most common drugs that we use in the U.S. for corneal ulcers are fluoroquinolones. One of the problems with fluoroquinolones is the first generation or third generation, if you would. Basically, we're very ineffective against gram-positive organisms. The fourth generations are more effective, both against gram-positives and mycobacterium, but there are still significant holes. If you look here, if a patient has methicillin-resistant staph, and this is from the Ocular Trust study, they are almost assured to be resistant to the fluoroquinolone. So if you have a resistant staph aureus, for example, the likelihood is it's both resistant to methicillin, penicillin, and those drugs, but also to fluoroquinolone. So it's not appropriate necessarily to use the two together. The good thing is that there remains vancomycin, which has been used for decades now, which remains still very effective against most of the gram-positive isolates for the eye. But people have shown that there are significant increases in the MICs that are necessary in order for those gram-positive organisms to be sensitive to vancomycin. So this is called a creeping baseline, is really an indicator that soon we will see resistant gram-positives against vancomycin. So it's important to look at other options. Just briefly, this is a case that we've reported before. This is a 63-year-old woman who basically had been referred to us from outside ophthalmology. She had pain and decreased vision in her right eye. She had a large infiltrate in her right eye that had a very unusual appearance. She had been started on antibiotics and taken off of them repeatedly without success. Cultures were taken about 3 weeks prior and also at our visit. She was sent to us because her original culture only showed a few gram-positive cocci. She was intolerant of vancomycin because of the severe pain, as you may note if you've prescribed it for patients, and was unwilling to take that again. And she had had LASIK and eyelid surgery, so she had a lot of components of immunocompromised ocular surface. You see very clearly here that this patient has a very unusual branching structure to this infiltrate, which had basically started in the superiotemporal quadrant and was crawling across her visual axis. Her visual acuity is now down to 2500. Her pupils are otherwise eagle and round and reactive. The rest of her exam appeared to be relatively normal, but severe injection. You can see here a closer view. And this is really a classic appearance for infectious crystalline keratopathy. The most common organisms are going to be strep viridans. Candida has also been reported, Pseudomonas, but largely these are gram-positive infections. Well, the pathogenesis is interesting because these organisms have the ability to form biofilms, and what happens is they infiltrate into the cornea, they form a biofilm to protect it from the host's immune system, so there's very little necrosis, but there's also an inability of the host to clear these because of that lack of necrosis and lack of inflammation. So she had tried vancomycin, as I mentioned previously. We had offered this to us. She was not interested. So getting back to rabbits, we had done a study actually several years prior looking at other candidate compounds for gram-positive organisms. We had tested not only against vancomycin, linazolid, daptomycin, and tigecycline. And we were able to show basically that the rabbits really liked the linazolid more than the other, certainly more than vancomycin. So we use that as our candidate compound. And you can see here that really the colony counts, it's very effective against strep pneumoniae as a topical treatment in these rabbits, and really had fairly equal efficacy to some of the other antibiotics. So in this patient, she agreed to use topical linazolid. We started this, and for any of you who have ever had to treat infectious crystalline keratopathy, you realize that it often takes weeks for you to see a response. In her particular case, the infection responded after about a week or so. She was pain-free actually after 2 days, and her best corrected visual acuity 1 month later was 20/25 in this eye. So it was very effective, and this has been repeated. We've had a lot of infectious crystalline keratopathy patients, both in our institution and abroad, that have had very good effects. The nice thing about this is that it is compounded from an IV solution without any other alterations. So you basically take it from the IV bag and you put it in an eyedropper bottle, and they can use it. It's slightly acidic, but is really actually very comfortable compared to vancomycin. This is another case that we had. This is a patient with VRE, or vancomycin-resistant Enterobacter. The scar that you see on in the bottom right is actually from a separate Candida infection the patient had. She actually had an ulcer in the superior-temporal quadrant with vancomycin-resistant Enterobacter, which also responded very quickly to topical linazolid. So in summary, clinical use of topical linazolid, this is a 0.2%. It's a simple topical formulation. It's a Q1 hour administration. It's good against VRE. It's good against certainly against MRSA. There's been since its introduction in 2007, the amount of resistance to the drug has been very, very low. It's a synthetic antibiotic, so not something that's found in nature. Very comfortable formulation. It does, however, apropos Enzo's comments on corneal tissue, is a very expensive formulation as far as compared to vancomycin, which is an older drug. But in those patients who are either intolerant to vancomycin, have significant ocular surface disease, or have a significant resistance, this is an excellent, very effective option that you can put into your armamentarium. It also is effective against atypical mycobacterial keratitis, specifically Mycobacterium chelonae. Thank you very much.